Hi, and welcome back to Perioperative Nursing for Basic Nursing Concepts. This is Tracy again. And we're going to move on and take a look at the older adult now. We kind of touched on our pediatric and infant patient, but now we need to think about the other end of the spectrum and our older adult and changes of aging. With changes of aging, we will see decreased function, and unfortunately, as we all know, as we get older, things tend to slow down. We get a little more tired, and the same thing with our body organs. They get tired, so we do see decreased cardiac output, and cardiac output is reliant on heart rate and stroke volume and how effective that heart is pumping, which also leads into peripheral circulation. How many times have you held on to the hand of an elderly person and their hands are just really cool or cold to the touch? The vital capacity, how much blood oxygen do they have? If they're having decreased circulation, decreased perfusion, that's going to kind of dovetail right along into that. And actually, if you would take a look at page 246, chart 16.2 in your IGGY book, you will see all of these risks listed out there. And plus a few more. So I would just ask that you take a look at that and be aware of the differences in how the older adult is going to tolerate surgery. They do have a decreased ability to tolerate the stress of surgery. So oftentimes maybe they may not perform surgeries because of the age. We see hypertension a lot in our older population. Risk for skin damage and infection. Think about how frail the elderly skin is as they age. Maybe they are poorly hydrated, have poor nutrition, those types of things. That's going to set them up for risks, which leads us into the next slide. We need to consider chronic illnesses, which I've expressed several times now. Malnutrition. I think about malnutrition and I think about the older adult that maybe gets Meals on Wheels at home. Meals on Wheels provides one meal, typically Monday through Friday, to clients that are homebound or aren't able to cook for themselves. So sometimes they'll take that one meal, divide it into two, and are they really getting the nutrition that they need, and are their nutritional needs being met? Impaired self-care ability, are they able to care for themselves, wheelchair bound, utilizing a walker, those kinds of things. What allergies do they have? And even including the tape allergies is something, because we knew when we are looking at their skin, we know how frail and fragile their skin is. And then what type of support system do they have? Do they have the support necessary upon discharge? We have discussed some of the cardiopulmonary complications after surgery, especially if you have an older adult that has already had some kind of cardiac event or maybe has hypertension, coronary artery disease, stress from surgery and anesthesia itself. When you think back to fluid and electrolytes that were discussed a little earlier, we know that with kidney failure, their ability to excrete and metabolize the anesthesia is going to be very different and can cause complications that way. Mental status changes, oftentimes if they might be alert and oriented in their home, but then they come to the hospital and by goodness, this new and changed environment and new people, they aren't able to adapt and change to what the current environment is, and then they're going to be at risk for falls, especially if they have mental status changes. And we know that the initiatives are to keep our patients safe, so we do want to provide a safe, clutter-free environment for them to live in. So the National Patient Safety Goals Commission is the driving force behind us keeping our patients safe. Yes, by the goodness of our hearts, we should be doing these things, but the Joint Commission and NPSG also really are a driving force behind safety. Let's move on now to laboratory and diagnostic assessment. So these are some of the things that our patients may be experiencing prior to surgery. Oftentimes, the diagnostic and laboratory tests that are ordered are very dependent on the facility, dependent on the patient's current conditions, when their current medications. For example, if you have somebody on warfarin or Coumadin, that's a blood thinner, so that would lead us into clotting studies, and those patients are going to need to stop taking the Coumadin, aspirin, those types of things 24, anywhere between 24 and 72 hours prior to having surgery, because we don't want them to have prolonged bleeding times and run the risk of hemorrhage while they are in surgery. Pregnancy testing: any woman that has a uterus that is not menopausal, even if she's had a tubal ligation, even if she's just had her period, must have a urinalysis to do a pregnancy test. If your patients are on diuretics, then that would lead into the following slide, that we need to be paying attention to their fluid and electrolyte levels. We need to look at their creatinine level, how hydrated or dehydrated they are. We always do a complete blood count, or at least a hemoglobin and hematocrit, because we want to know where people are starting out. What is their hemoglobin? So that if they would run the risk of bleeding during surgery, do they have any kind of reserves that they can pull on? And if you have a patient that has a hemoglobin of, say, 8 versus your patient that has a hemoglobin of 10 or 11, obviously you can kind of get that understanding that the person with the higher hemoglobin is probably going to do better. With fluid and electrolyte imbalances, hypokalemia is a low potassium. Hyperkalemia, high potassium. Oftentimes potassium does help, or potassium. Okay, back to the hyper and hypokalemia. Sorry about that. There's going to be increased risk for dysrhythmias, because our heart utilizes potassium with its perfusing capabilities, and so we want to make sure that our patients do have a normal potassium level. And oftentimes, you know that when our patients take Lasix, a diuretic, it is a potassium depleting medication, and so it's important to be assessing fluid and electrolyte balances. Other things that might need to be done: arterial blood gases, or ABGs, chest x-rays. As far as diagnostic imaging and diagnostic assessment, chest x-rays may or may not be included. Typically, if the patient has any abnormality or abnormal findings or any cardiac events, we will see chest x-rays being done. Or if the patient is typically over 60, we'll see a chest x-ray done. As far as the ECG, or electrocardiogram, these are on page 248 of your IGGI, by the way. We will look at the EKGs on anybody over 40 to 45 years old, and EKG, ECG are used synonymously. If a patient has had any cardiac events or is on any cardiac meds, we will want to make sure that we do take a look at those ECGs and look for any abnormalities in those, because if we would find an abnormal in the ECG, chances are maybe surgery would be canceled. So that's kind of a little summary of lab and diagnostic assessment. So the following couple of slides are iClicker questions. So what I would encourage you to do is take a look at these, answer them, tell me if it is elective, urgent, or emergent, and would you consider this a major or minor surgery? So as far as an appendectomy on this slide, elective, urgent, or emergent, minor or major surgery. How about a breast biopsy? Same questions. Elective, emergent, or urgent, major or minor. And one last one, a hysterectomy. Hysterectomy. Same questions again. Elective, urgent, or emergent. Major or minor surgery.